Thanks very much, Ruben. I did give a talk on this topic just a few minutes ago, but I'm going to try to highlight different features and also expand on particularly the immune and other therapies a little bit more than I had a chance to in a minute ago. But I always like to celebrate this slide because together we really have, I think, can be proud that we have, with our patients, changed the natural history of this disease. But, and as so nicely from Joe McHale just said, we have two new members of our team with pomalidomide and carfilzomib, but we still need to recruit some new rookies to really make a huge difference. And I think the other thing that myeloma represents is this slide, that is we can target the tumor and the microenvironment. And so we can target the cell surface, we can target cytokines in the microenvironment, we can target ligand and receptors that mediate the interaction. And I always like to highlight that when we try to target the circuits in a myeloma cell with so-called targeted therapies, remember that those same pathways are implicated in the biology of the accessory cells as well. So it truly is a model of targeting the tumor in the microenvironment. And I showed this before, but these are the current members of our team, at least as the NCCN defines it, which is based on data. The phase one, category one randomized trial members of the team are bortezomib, lenalidomide, dexamethasone, and pegylated doxorubicin bortezomib. And the new rookies on the team are pomalidomide and carfilzomib, having been chosen and drafted for the team on the virtue or basis of phase 2 clinical trials. And I showed this upstairs, but it's just to remind you that when lenalidomide dex was tested in 2 different trials, one in North America, one outside of North America, in relapsed refractory myeloma, and compared to high-dose dexamethasone, it actually was superior. Why? There were about 60% overall responses in patients 1 to 3 prior therapies. A quarter of the patients got a complete response. People had durable responses and lived on the order of 2 to 3 years. Bortezomib was compared to high-dose dexamethasone, also in relapse patients, 40% or more responses, durability, and patients living again 30 months. And pegylated doxorubicin combined with bortezomib based on the preclinical science showing, Jim Berenson was leading this effort, that if you add a proteasome inhibitor, you can block DNA damage repair that's done by the DNA damaging agent, whether that be an alkylating agent like melphalan that Jim showed, or doxorubicin here. Anyway, there was a randomized trial with pegylated doxorubicin bortezomib versus bortezomib, which was positive. Now, I showed this upstairs, but it'll be interesting in our discussion, but I think although bortezomib in all those 2 trials that I mentioned has been given twice a week for 2 weeks by vein with a week off, Antonio, who I have to tell Dr. McHale, that do not pummel somebody from Italy. This is a really bad idea. But in any event, he's our friend, as a mutual friend, our brother. But in any event, what he taught us was to use bortezomib perhaps once a week instead of twice a week, because in his clinical trial, when he did that, as shown so nicely here, he could cut down the incidence of neuropathy by half, and the incidence of grade 3 or severe was in the single digits. So many of us in the room utilize bortezomib now weekly instead of twice weekly, at least after the first couple cycles. And then the French taught us to use bortezomib subcutaneously rather than intravenously. The efficacy in their study was roughly the same, but in fact, as shown on this slide, when the dose and schedule were the same, but it was given subcutaneously, again, the neuropathy was reduced, and so was the severity. So what's practically done among all of us in the room, I think, is we often now give weekly and subcutaneous bortezomib. At least in our experience, that has made it much more tolerable, allowed us to go into first patients to remain on it much longer. Secondly, to study things like maintenance bortezomib in a much more user-friendly way. So when do we think about treatment? And again, I won't dwell on this much, but the idea of somebody having a reappearance of a protein or a slight rise in their protein, which we call a biochemical relapse. Now, traditionally, what this slide says, and you heard upstairs, we wait for CRAB, right? Hypercalcemia, renal dysfunction, anemia, and bone disease. We actually have a few other things that have been added: hyperviscosity, recurrent infections, and neuropathy. But the truth is, we don't often wait for those if you actually have a trend that's real and rising. So you do need to follow people over time. That's an important message. But if there's, in fact, a real trend upward, as Susanna Lench said upstairs, we often intervene rather than letting CRAB develop. We have effective agents now, so we try to intervene. Having said that, if somebody has an indolent relapse that has actually no change in time, that probably doesn't warrant right now intervention. But I don't think we wait traditionally for complications to occur. And then what are the things that we think about when somebody has therapy? Joe mentioned a minute ago, sometimes class switching. That's like B-cell biology, but he meant switching from a proteasome inhibitor to an immunomodulatory drug. So that's one consideration. But I think thinking about the response to prior therapy, and I think there I would just mention to you that, if you have somebody who has been sensitive to an agent before and they relapse 6 months or more later, you can restart that agent. As it turns out, in the era of novel agents, even patients who are refractory to a given agent, as I mentioned upstairs, can be sensitive if you add in a second one. So I mentioned the example of bortezomib or lenalidomide, where patients were resistant to one or the other. When they were put together, 60% of the time people had a response, and there are other examples like that. So this slide basically tells us that we're all going to still have a job, because people need doctors to help the patient's guide in an individual sense what is the right choice at a given point in time in their illness. So I showed this, but I'm going to spend more time on some of it now. The immune therapies in particular. Here are the antibodies that I mentioned, and I do want to highlight even more the excitement that I have, and I think is shared by some of my myeloma colleagues, for the antibodies. I have had interest in this since 1980. Our laboratory did work on CS1 antibody elotuzumab, and I was one of the first people that described CD38 in the early 80s. But honestly, we have not had a high success rate, but that's really changed. So the promise may finally be delivered, just like the Red Sox may finally win. So here is elotuzumab. So elotuzumab is directed at CS1 as a single agent. CS1, I should say, is an antigen at a gene and protein level on everybody's myeloma. Single agent elotuzumab antibody achieved stable disease in relapsed myeloma, but no responses. The preclinical data said add lenalidomide to this elotuzumab, and in so doing increase antibody-dependent cellular cytotoxicity. As a consequence, that was done. And here is the randomized phase 2 trial actually phase 1, phase 2 trial that Sagar Lonial is now the PI of. But it compared elotuzumab at 2 different dose levels, 10 milligram versus 20, together with lenalidomide dexamethasone in relapsed myeloma. This is a so-called waterfall plot. That's the score of the St. Louis Cardinals dropping on the left here and on the right. It didn't matter who was up. Okay, it was great, actually. I was there. So 10 milligram versus 20. And the other thing that this slide shows you is more is not better. I like that too. I think short is better. But 10 milligrams here actually showed saturation of the myeloma cells. So the dose that was chosen to go forward was 10 milligrams because it saturated the site. Here's the very exciting data. So in relapsed myeloma, the response rates I mentioned were 80 or 90%. But here is, in fact, the progression-free survival. And you can see there that the 10 milligram dose, which is the green line, is still above the 50% mark, and it's out at 33 months. So these responses in relapsed myeloma of the combination of Lendex elotuzumab are really meaningful. And so here is the summary that it's 80 or 90% response, and they can be durable. Remember, lenalidomide high-dose dexamethasone, the PFS was around 11 months. So this looks to be very different. The other thing I mentioned upstairs that I'll highlight again here is that so far at least there are some of these responses occurring in patients who have the p53, 17p deleted myeloma. So maybe the immune mechanisms will be able to be active in the context when other strategies aren't. Here's daratumumab. It's directed at an antigen that was originally described on activated T cells called T10. Later it was called CD38, but it's on activated B cells, T cells, monocytes, granulocytes, and endothelial cells. That's why for 30 years it was never gone forward in the clinic. But fortunately it has gone forward in the clinic now, and one of the antibodies to this CD38 antigen is called daratumumab. There are two other ones. But this one actually does, as shown on this slide, trigger ADCC, complement-dependent lysis, and in fact, if you cross-link CD38 on the cell surface, you can directly trigger death signaling. This is the waterfall plot again. And on the right-hand side, if you look at 4 milligram per kilogram dose or higher, you can see that the waterfall starts. And this includes, in some patients now, a complete resolution of their paraprotein. So this is as a single agent, no lenalidomide dex at least added at this particular trial. So in far advanced myeloma, this is the very, very early data, but nonetheless, it did show some remarkable activity. And this drug has been given or granted breakthrough status by the FDA, which means it will be on the fast track if have to prove itself to be efficacious, but it's on the fast track for approval. So those two, remember, elotuzumab and daratumumab. And I showed this upstairs. I just want to mention it again. I do think we're in the era now where vaccines may actually be able to come forward in myeloma. This is just one example of many. We have a couple ongoing, and I'm sure there are other protocols that you're aware of. But this one is one where you fuse the dendritic cell to the myeloma cell from an individual patient. In so doing, you take the antigen-presenting function of the dendritic cell and you present the entire evil myeloma cell as a foreign antigen. And we can show that you get B cell and T cell responses in that context and stable disease, even in relapsed disease. But as I was saying before, this is an opportunity now for combinations of immune therapies. If you vaccinated and can get a selective response, we have ways now, such as the checkpoint inhibitors that I mentioned upstairs, to take the brakes off the immune system and upregulate it. If you add immunomodulatory drugs to vaccines, that's going to work too, because we've recently shown that immunomodulatory drugs, lenalidomide and pomalidomide, target regulatory T cells. They're active in myeloma, and their job is to suppress the immune system. So there's a strong case for adding IMiDs to a vaccine also. So combinations of immune therapies, I think, are coming into the future. I mentioned the proteasome inhibitors before. The only ones I'm going to mention here, again, are the oral ones, but I'll be a little more extensive. The Millennium drug, so this is the son of bortezomib. You know, all the kids are stronger than their parents, right? So this one is a boronic acid oral child, okay? And it's shown here to be active against myeloma cell lines, against myeloma patient cells, and against the bortezomib-resistant myeloma cell line in the center there at the bottom. This is a trial from Shaji Kumar at the Mayo Clinic, where he did a phase 1 trial of this agent. It's actually now called ixazomib. Yep. Anyway, that agent has been tested in patients who have relapse refractory, bortezomib relapse, proteasome inhibitor naive, and patients who had carfilzomib. What Shaji showed was, in fact, this agent was very well tolerated. Again, it was only given once a week orally. You can see here that, in fact, neuropathy was very infrequent. And there were responses, even in this phase 1 trial where we didn't know the dose, about 20% of the time, and another 30% of patients getting stable disease. Now, Paul Richardson at our place did the same kind of a trial in the same kind of patients, only he gave the drug twice a week instead of once a week. Its half-life is 3 to 4 days, so either way probably is sufficient. But in any event, in his study, Paul's study, 46 patients were enrolled. 7 patients responded and 28 had stable disease. So again, we had activity here, and this included some patients with bortezomib refractory disease. What's exciting is, and I think this is, I hope, the future in myeloma, Shaji and Paul in different ways have combined this agent, MLN9708 or ixazomib, with lenalidomide, dexamethasone, just like we heard about bortezomib, lenalidomide, dexamethasone, or carfilzomib, lenalidomide, dexamethasone, except this one's all oral. So wouldn't it be neat if we had an all oral regimen for newly diagnosed patients? And you can see here that the responses are actually a little bit slower, but the ultimate goal here, the majority of patients, if not all, will ultimately respond to an all-oral regimen, and this is Shaji's weekly study. Now, there is a son of carfilzomib. It was originally called Onyx 0912. Now it's called aprozomib. And on the left-hand side here, it's killing myeloma cell lines that are resistant to standard and new drugs. On the right-hand side, it's inducing death of myeloma patient cells. And the clinical trials are early, but they are, in fact, positive or looking very promising. What's happened with this agent is a change in the formulation. The original formulation had GI toxicity, so we're sort of at an earlier stage here than we are with the Millennium drug at the present time. I showed this upstairs, but this is a more broad-acting proteasome inhibitor, marizumab. It shows here in the red that it blocks the chymotryptic, in the blue it blocks the tryptic, and in the green it's blocking the caspase-like activity. Those are the 3 activities of the proteasome, the constitutive activities. And we don't know whether if you block one, the cell can compensate by upregulating the other 2. So this one is testing preclinically and now clinically the concept of whether you can be more broad in your activity and in so doing have more clinical benefit. And it's too early to tell, but the trials are ongoing. Here is just to summarize the responses, and all we can say is that there are responses occurring, and time will tell whether this is a better strategy or not. This agent is IV right now, but there is a normal oral formulation underway. And then these are some of the other ones. I mentioned the bromodomain inhibitors and the BTK inhibitors upstairs. I do think those are on our list of the favorites, but the KSP inhibitors, the kinesin spindle inhibitors, AKT inhibitors, nuclear transport inhibitors, and CDK inhibitors that Dr. McHale and Stewart have studied, or as we heard about this morning from Selena Cheng, she gave a nice talk on her experience, but those agents are looking positive either as single agents or in particular in combination with bortezomib. I showed this before, but I think I want to highlight for you, this is really, I think, critical. What do myeloma cells do? They make protein. They're uncontrolled in their making protein. So what is their Achilles heel? It is to block their ability to deal with all of this protein that they themselves are making and let them fill up with their own protein and commit suicide, to put it in plain English. Sort of like what happened with the Yankees this year. Remember? Ooh, sorry. Well, look, we've been waiting a long time, okay? We've been waiting. No, teasing. But in any event, so here we have the idea of blocking the proteasome with all those agents I've talked about already, and on the left-hand side, blocking the other pathway, the agrisome, with the HDAC inhibitors. And I mentioned the broad one, varinostat, and I mentioned the selective one right now called AC1215. And the reason the selective one is rational, as you see on this cartoon, is HDAC6 is sort of the shuttle mechanism. It takes in the protein on the one hand, and it binds to the dynein microtubule complex on the other, and it moves the garbage into this agrisome, other garbage disposal. And I mentioned that Thanos Donopoulos has already tested this dual blockade of the garbage disposal concept. He has a paper coming out in Lancet Oncology, which is a positive trial. It was done in 38 countries and like almost 200 sites, and it was a positive trial, but the sad part of it was that because of side effects, the patients couldn't stay on the drugs even though they were responding. And so we're hopeful that this more selective inhibitor that I mentioned to you, alone or in particular combined with the proteasome inhibitor, and I won't have time today, but combined with the IMiDs as well, might come forward as new combinations. And the final comment and the final slide is this one about the signatures again. You've heard an awful lot about how we and others are going to use DNA sequencing, RNA sequencing to try to come up with genetic signatures. But remember, we have to do that at multiple points in time, at the time of diagnosis or at the time of relapse. And honestly, we've recently had an experience with Dr. Munchie that shows that at the time a patient presents with their myeloma, they have on average 56 mutations, okay? And we can sit here and argue about who's driving and who's the passenger, but we are dealing with a terrifically complex disease which gets worse with time. So my plea is we need to do these signatures. We can find certain things like the BRAF mutation, and there might be a drug on the shelf such as venurafimab we can use. But in my opinion, we need to manage the expectations here, because we're not like CML, we don't have BCR-ABL. We're not like hairy cell leukemia that had this same mutation, BRAF, in 100% of the patients. Nor are we like Waldenstrom's that has the MYD088 mutation in the majority of patients. We don't have that in myeloma. We're unlucky, so we're going to have to spend some time figuring this out. And my plea is that we manage the expectations, that we figure out what is the biology behind it, what are the pathways that are implicated, and let's together use combinations to get as early as we can and try to deal with this genetic heterogeneity. So that's the future in terms of what I wanted to say, and I guess I'll stop here at this point. Thanks.